The session for today is heart disease, current best practice management, and what we'll cover is we'll look at the guidelines for best practice management of heart disease in Australian primary care specifically. We'll have a look at how to use the absolute risk calculator, but also what is absolute risk. We'll discuss some of the psychosocial risk factors for coronary heart disease. We'll have a look at an overview of lipid and hypertension management. And we'll discuss a little bit about the role of GP management plans in heart disease. We'll also wrap up with practice systems to improve patient engagement in managing their care, specifically when it comes to heart disease. All right, so let's just start with a bit of background about heart disease in Australia and some of the stats. We know that 1 in 6 Australians are affected by cardiovascular disease, and this accounts for more than 3.7 million Australians. So it's not a small issue. In terms of the burden of disease, we know that heart disease is the single leading cause of death in Australia, with over 19,000 Australian lives lost to heart disease, and that's 2013 alone. Cardiovascular disease, or CVD, is also the most expensive disease group. So with a cost of about over $7 billion, and that was just for the 2008-2009 period, and more than half of this expenditure is spent on patients who are admitted to hospital. Overall, and this is not unique to heart disease, we see this in diabetes as well, people with in the lower socioeconomic groups, those of Aboriginal and Torres Strait Islander background, and those living in regional and remote areas have higher rates of hospitalization and death from CVD. Here's a little map from the Heart Foundation that shows the prevalence of cardiovascular disease in Australia. We actually will provide, as part of the CPD module, in the list of resources and links and downloads, there'll be links to all of these resources, so you'll be able to actually click through and go to the maps that are specific for each state, which obviously will give you even more granularity and detail in terms of prevalence, incidence, and the burden of this disease, depending on where you are. We can see from the screen, and hopefully you'll be able to see this well on your screens, the areas that are shaded in that dark maroon color are the areas with the highest incidence or highest prevalence of cardiovascular disease, and that's over 23.66%. The next color down is the orange, that ambery color, that's medium prevalence, and that's between 18.9 to 23%. Then the yellow is low prevalence with less than 18.95%. And the gray areas, which is a fair bit of Australia, is just where we don't have any data available. As another bit of information for you, all the information that I'll be sharing with you as part of this session has been gathered from either the Heart Foundation, approved peer-reviewed guidelines, and as well from the Alliance, which I'll talk a little bit more in a second. The other thing that I wanted to highlight is this statistic. On average, 1 Australian dies as a result of heart disease every 12 minutes. What that means is during the length of this session, that's probably around 3 Australians who will, or the equivalent of 3 Australians who will die as a consequence of this disease. So it's just to highlight the importance of obviously looking at proactive ways to actively manage or prevent this condition in our practices. In terms of guidelines for best practice management, a lot of the resources, as I said, can be found in the heartfoundation.org.au website, and they actually have a section that is for health professionals with obviously all the particular clinical information, as well as a wealth of resources for patients. But what I would like to bring your attention to is all the resources that are there for clinicians. In terms of what you'll be able to find there are guidelines, tools, and other resources around absolute risk, acute coronary syndromes, and that entire list that you see there, hypertension, lipid management, and even GP resources. So in the GP practice resources, there's actually care plan templates, so GP management plan templates for coronary heart disease, which I'll also show you in a moment. Now, I was talking about the Alliance. There's a National Vascular Disease Prevention Alliance, which was formed in the year 2000, and it's the 4 leading Australian charities, so Diabetes Australia, Kidney Health, Heart Foundation, and the Stroke Foundation, who joined forces and established in 2000 this alliance in order to reduce cardiovascular disease in Australia. So a lot of the resources that you'll see here have actually become available as a consequence of this alliance, and they have been produced from this alliance. Now let's talk a little bit about absolute risk. By now you probably would have heard about absolute risk. There's a fair bit of information about it, and it is considered the best practice or best way to approach heart disease management or assessment in general practice today. So when we talk about absolute risk, we're talking about the assessment of cardiovascular disease risk based on the combined effect of multiple risk factors. Yeah? So this approach we know is more accurate than using just individual risk factors. So in Australia, we know over 64% of adults have 3 or more modifiable risk factors. So what do we mean by that? We mean smoking, alcohol, lack of physical activity, poor nutrition, and these sort of things. So we know that the absolute risk approach leads to much better management through lifestyle changes, and then where applicable or where needed, then it informs what pharmacological therapy will be undertaken. What does absolute risk actually mean? When we look at absolute risk, we're talking about the numerical probability of a CPD event within 5 years. So in layman's terms, for example, if you have a patient who, when you do the absolute risk calculation, which we'll cover in a little bit, you have a patient whose risk is 15%, it's always expressed in a percentage, then you can tell them that obviously 15 out of every 100 people who are like them are likely to have a cardiac event. I would actually use more health literacy or patient-friendly language like a heart attack or stroke over the next 5 years. Again, so that would be, if you've got a patient with 15%, look, actually what this means is 15 people out of every 100 who are in the same situation as you will likely have a heart attack or stroke over the next 5 years. That's what that means in terms of your risk profile. Now, in terms of the management goals, or what we're trying to achieve with this absolute risk measurement and approach, is to reduce the patient's level of absolute risk, so their overall level, which is achieved by managing several individual risk factors, not just by targeting, say, their blood pressure alone or their cholesterol alone, or whether they smoke or not. Yeah? This is because evidence shows that moderate reduction in several risk factors is much more effective than trying to reduce overall risk by just addressing one risk factor. So an example of this, you might have a 55-year-old female patient who is fairly healthy, fairly good profile in general, but her blood pressure might be, over 155, systolic. And so if you look at it, you go, well, look, actually, even though their blood pressure is a bit high, when we look at the overall risk, they're actually sitting in a 3 to 4% of absolute risk, because all the other factors, her sex, her cholesterol, the smoking status, everything else is quite protective. With that patient, if we were to go very aggressively into trying to bring down that blood pressure, the actual impact in terms of reducing that the risk of a cardiac event might go from maybe 4 or 5 down to 2 or 3%. So it's not a huge impact that we see. If on the other hand we have a patient whose overall, same 155 systolic blood pressure, but the rest of the profile is much more complex, and it's bringing up their risk profile to 15% or even 20%. If we address multiple facets of that, and it doesn't have to be a drastic or aggressive reduction in that one blood pressure, but addressing multiple areas, we'll actually might be able to reduce by 5 or even 10%, which would be considerable. So again, the aim of the absolute risk approach is to just have a holistic approach to managing and preventing heart disease, as opposed to just trying to focus individually on just cholesterol or just blood pressure, which is what historically we would have done. Now, you may be familiar with these charts. So these are and I quite like using these charts with patients because it's obviously very visual. You have a color scheme of risk. And the way we use these, there's two charts. One is for people without diabetes and one for people with diabetes. So this is the one for our patients without diabetes. The way we would use it is, as you can see, you've got a section for women and men. You would, depending on the patient that you have in front of you, so we had that patient was a female, so it would be women. Then you have the option of non-smoker or smoker. Yeah. So then, okay, so if this patient is a non-smoker, then we actually have a look at their systolic blood pressure on the left. From the systolic blood pressure, which is going from 120 all the way to 179, that would dictate then obviously the height of the cube that we'd be using. And then at the bottom, we've got the indication of the total cholesterol to HDL ratio, which would again move us across to a particular box. Depending on obviously the color of that box, you'll see the legend underneath that says, obviously, if you're falling into one of the boxes that is, red, amber, or yellow, you're at high risk. If you're falling in one of the blue boxes, then it's moderate risk, and any of the green boxes are low risk. So it's fairly visual. And again, when I use this with patients, it makes it quite clear, or it helps that communication process of communicating the risk. And they can see what are the factors that are moving them towards those higher risk colors. This next chart is exactly the same thing, but for people with diabetes. And as you can see, the immediate difference as soon as you see it is there's considerably more red and amber coloring and a lot less of the green shades. Because as we know, obviously people with diabetes are immediately at a much higher risk of cardiovascular disease. Now, there are some limitations with this tool, and you'll find that a lot of your clinical softwares actually have this built into them, and it might be a calculator, so it'll usually be an absolute risk or cardiovascular risk calculator where you just plug in the figures and it'll calculate it for you. I still quite prefer to use the visual charts just because it enables that conversation with my patient. Having said all that, again, there are some limitations to this process. So for the Framingham risk equation, which is what we're using to calculate this, there are some limitations. Some of these are, it may underestimate cardiovascular risk in the following groups: in Aboriginal and Torres Strait Islander people, in adults with diabetes who are aged between 45 and 60, in adults aged over 74, in adults with socioeconomic deprivation or of lower socioeconomic state, because that is an independent risk factor in and of itself that would aggravate or increase their risk, the overall risk profile. But the other issue is that this model or this equation we don't actually have a predictive value of using this tool to assess the risk in adults who are overweight or obese. As you can see from the tool, nowhere there do we mention, their BMI or, their weight, height, or anything along, or even fat, their body fat percentage or anything like that. So it's not really, there are some factors that it's not really taken into consideration, okay? Remember, if you've got any questions as we're going through the live presentation, just type them into your questions box and then we can address them at the end of the presentation. Now, in terms of, once we have a reading or a value for absolute risk or a level for our patients, what do we do then? How do we tackle it? The Alliance has been actually quite good in putting together so many wonderful resources, and this is just one table of a wealth of documentation and resources that, again, I will be including as part of the links in the CPD module. But this handy table just shows us, well, what would be the approach depending on the risk level that the patient falls under. So we have obviously the risk, either high, moderate, or low. Then we have a column that looks at lifestyle. So what are the recommendations or things that we'd be looking at from a lifestyle point of view? Pharmacotherapy, whether or not it would be recommended. Then we have targets. As you can see, the targets are consistent across the three risk categories or 3 risk levels. And then finally, we have monitoring, which is obviously looking at how frequently we would be following these patients up and what would be those next steps. So if we look at this in a bit more detail, so in terms of someone who's falling under that category of high risk, the lifestyle intervention would be frequent and sustained specific advice to support their diet and physical activity changes. Yeah? When we go down into the moderate risk, it just loosens up a bit to go in just appropriate and specific advice, but it's not as frequent and sustained or intense as obviously with our high risk patients. With the lower risk patients, it just becomes a brief general lifestyle advice. Yeah? If we move over to pharmacotherapy, we'll see that the high risk will usually be treated simultaneously with lipid lowering and blood pressure lowering medication, unless contraindicated or clinically inappropriate. If we move down to the moderate risk and even low risk, we see that the first line is that pharmacotherapy is not routinely recommended. Why is that? Obviously because we're looking at trying to manage these risk factors with non-pharmacotherapy ways. So more looking at the lifestyle modification options and referrals to allied health as appropriate. So that could be exercise physiologists or dietitians to support and those things. When we look at the targets, fairly straightforward. We have our lipid targets, lifestyle targets, and blood pressure targets. With lifestyle, again, smoking cessation, which is quite consistent across the board. Very basic diet advice, knowing that obviously if you have a patient who's willing and who needs it, referrals to dietitians or health professionals that have a specific focus on that is going to be a lot better. And physical activity. So again, with physical activity, I always love to at least offer the opportunity to patients, regardless of whether or not they're going to be eligible for a management plan and a team care arrangement, offer the opportunity of a referral to an exercise physiologist. Yeah? Obviously, if they're not going to be qualifying for a team care arrangement, or which will allow for some subsidy of the funding of those sessions, you just explain that there would be costs associated with those services, but leave it up to them to decide whether or not they want to pursue that line. A lot of times we don't even offer those avenues because we assume that the patient's not going to want to pay for these services, but that's often not the case. A lot of times if a GP or any health professional recommends an intervention, even if there's a financial value attached to them, a lot of people will actually go, yeah, I'll try it. I'll give it a try and see how I go. In terms of monitoring, it's fairly consistent in terms of the recommended interval tends to be between 6 to 12 weeks. The thing that changes is the next steps. So at 6 to 12 weeks, we'd either be looking for improvement if they're in the high risk, or if they're in the low risk. 6 to 12 weeks, again, we might be looking either at reassessment or more softly looking at the general lifestyle issues. The other thing that is quite interesting from this is from the pharmacotherapy column, you'll see that the final paragraph in each one of those sections, regardless of the risk level, is consider withdrawal of therapy for people who make profound lifestyle changes. Yeah. So that is consistent across all risk levels. So if you have a patient who's actually taken up their, they've changed they improve their physical activity levels or drastically change their diet, they're getting really good weight loss milestones, then always consider or reconsider the pharmacotherapy that they're in and whether we can either scale it back or if it's even necessary at all anymore. One of the things that has come up as part of having the absolute risk tools is that even though we've had them for a while, they've done studies to see, well, what's the utilization in practice? How many of these patients, then anyone essentially over 45 would benefit from having an absolute risk assessment? But how many of these patients have actually had one of these assessments done? Even though we know that obviously it takes a little bit of time, you can't really rush through these things. It'll usually take around between 10 and 15 minutes by the time you take into consideration the assessment, but also the discussion around what it means and what the implications are or what the management would be. They found that actually the uptake of the absolute risk assessment was still relatively low when you consider the number of people that you could be reaching and supporting or helping with this. So when they started looking at, well, why is this? Why aren't clinicians using this tool a lot more. And one of the issues was the fact that the conversation with the patient, well, one, obviously it's time consuming, but more importantly, it was difficult to communicate that risk in a meaningful way. What do we mean by that? When you get a percentage, you go, oh yeah, your risk is 15% or 20% or 30%. Well, okay, well, what does that mean, doctors? Well, that means that, 30 people out of 100 that are in your situation are going to have a heart attack or stroke. Still, what does that mean? It can be quite abstract for a patient to try and translate that into something that resonates. So what they looked at is, well, maybe we can present this information in a slightly different format, just for the sake of communicating that risk. And the result of this, and this is a tool that's being trialed at the moment, but it is available for anyone to access, and it's even available online for free. And it's what they call the Heart Forecast tool. So what the Heart Forecast tool does is it takes in, you plug in the values of obviously the risk profile, or the modifiable factors, or all the different risk factors, and it'll walk you through not just obviously what your risk level is, but it will take you further to give you recommendations and also tell you what your heart age is. So for example, if you have a patient who's 45 years of age and you go through the tool and it actually says, well, actually your heart age, so you actually have the heart of a 60-year-old or 70-year-old, which is not very good. Yeah, and that actually seems to resonate a lot more with patients going, oh, I have the health of my heart is that of a much older person than what I should be. And the contrary, or the opposite scenario of that, you might have a 60 or 70-year-old, you go, fantastic, because of your risk profile, you actually have the healthy heart of a 35-year-old or a 40-year-old, which could obviously brighten up their day quite a bit. In terms of what as you can see, is quite visual, or tall graphs and colors. And it even allows you, when you start getting into the higher risk groups, it even allows you, you'll be able to see on the right, to modify different things and see a new projection. So in terms of the colors of the lines, the red line is the current risk for this patient. The blue line that's at the bottom would be the ideal risk zone where we want them to be sitting. And the green line is showing us if we change, or if the patient changes some of these factors, what difference that's going to make. So for example, here we've ticked, what happens if I quit smoking, in the long term? And we see that risk considerably comes down. What happens if my blood pressure, if I manage to get on top of my blood pressure and I bring it down to 130 or 120, again, that'll change in real time. Same with cholesterol. What happens if my cholesterol goes up or down? What happens if I develop diabetes? And then they can actually immediately see the impact of all those different things. So hopefully that's a handy tool, and I would highly recommend that you go check it out, even if it is just for yourself as just out of curiosity. You can just Google Heart Forecast tool, and it'll be one of the first results that comes up. I've given you the link underneath, and obviously the link will also be available as part of the resources. Now, when we look at lipid management, we still have to bring it back to think about absolute risk first. Instead of just trying to go head first and tackle that lipid value, take a step back and look, well, what's the absolute risk profile for this patient? And then we can take it from there. I've actually given you this is a reference guide for health professionals called the Absolute Cardiovascular Disease Risk Management. And it has a lot of great information in terms of, okay, if we are looking at specifically addressing lipids, what do we do? What's recommended? So I'll give you an example. So this is again from that guide. In terms of lipid lowering therapy, if we've identified from their absolute risk that actually, yes, it is an area that this patient would highly benefit from, we'd get a good impact overall. We've got flowcharts where we always start with considerable treatable secondary causes of raised blood lipids before commencing any drug therapy. Then we have the suggestion of in adults over 74 years, use clinical judgment to consider whether or not it's really going to be beneficial to start pharmacotherapy, on what the risks of the treatment might be, and when you take into consideration comorbidities and anything else that might be happening. Yeah. And then we move on to, okay, if we've met that criteria, first line statins, and then if that's by itself not really doing the trick, then we move on to our second line of medications. Then we have a bit more information in terms of, well, what about those patients who are intolerant to statins? What are options? Same with, well, what about if we have a patient with raised triglycerides? What are our options? Okay, this is actually, in a 30 to 45-minute session, which is what we have here, we can't possibly cover all of the variations. But what I want to make sure that you leave with is the actual peer-reviewed best practice guideline that you can go back to and assess for your individual patients or your scenarios, what's the best strategy to follow. Then in terms of hypertension, again, we bring it back to absolute risk first, see where the patient is sitting holistically, and where that hypertension is affecting, or if it's a small component, maybe we can address some of the other areas beforehand. So with hypertension, there is also a guide to management of hypertension. It says 2008, but there was an update in 2010. And again, it has flow charts and treatment guidelines where you go, okay, well, how do we tackle this? If there's any of the following present, grade 3 hypertension or anything like that, then okay, we'll go drug treatment immediately, and this is what we do. If not, then we need to obviously confirm hypertension, and what you'll again see as the common denominator is you'll often see that lifestyle modification popping up regardless of what box you're in. Yeah, because those lifestyle modifiable factors, yes, they take it's a harder work, or it takes longer to try and work with patients on that front. But as we know, obviously the impact and the benefit is considerably great, and much more sustainable. Also, the way that it affects or impacts on quality of life, aside from that, is huge. Okay, so I want to make sure that we cover also psychosocial risk factors for coronary heart disease. And things like, for example, we know that people who experience depression, those who are socially isolated, those who do not have quality social support, they are at greater risk of developing coronary heart disease. Some of the other areas that are often sort of talked about are things like, well, what about work stress? So if I have a patient who's under a lot of work stress, is that likely to affect or impact their risk for cardiovascular disease, but also for cardiac events? And in terms of, if we look at the evidence, we know that chronic job strain and people who have shift work, those things are associated with an increase, but it's a small increase in the absolute risk of developing coronary heart disease. With same with shift work, it's associated with a higher risk of CHD events. But again, the impact is still, when you look at it in the greater scheme of things, is still a lot smaller than something like smoking, wood, or having diabetes, or any of those things. If we look at social isolation, however, we know that after an acute event, so for example, a myocardial infarction, we know that it is associated with, if a patient is socially isolated, they have an adverse prognosis, or the outlook is not as positive or optimistic as we want it to be. Social isolation is an issue. Work stress impacts, adds to it, but not as big an influencer. Now, when we look at depression, however, in and of itself, we know that the prevalence of depression in patients with heart disease is actually quite high, with around 15% reported after an event. It's a no-brainer. It makes sense that we'd want to then address depression in these patients. With the same, and we have plenty of tools to address this, obviously with mental health assessments, mental health plans, and all the channels for treatment and management. In terms of the benefits, obviously if we're addressing depression, we're going to be improving quality of life. We know that it does have a flow-on effect to improve adherence to therapy, which again would help improve their outcomes. And we know that, potentially helps improve CHD prognosis. With another last thing is the Heart Foundation recommends that all patients with heart disease, or CHD specifically, be routinely screened for depression by their GP or the health professionals that they're coming in contact with. In terms of how we go about this, we actually have and again, I'm will give you the links, and you have them on the screen as well, for all these tools that have been made available, again, by the Heart Foundation and by the Alliance. In terms of screening for depression, you can do the quick screen, the PHQ-2, which is 2 questions, and you just want a yes or no answer. So it's during the past month, have you often been bothered by feeling down, depressed, or hopeless? Yes, no. During the past month, have you been bothered by little interest or pleasure in doing things? Yes, no. If you get a yes for either one of those questions, then we move on to do a full PHQ-9 questionnaire, which is this one here, which you actually would get the patient to complete themselves. So if you print it out, you just get them to circle different areas and add it up. And in terms of the score, you have here what the score means. So it's 0 to 4, none to minimal, up to 20 to 27, which would indicate severe depression. Let's talk about the role of GP management plans or care plans in heart disease. We actually have a module. There's a free CPD module that's right now available through the Hot Doc blog. That's called Using Smart Recalls to Improve Care Plans and Health Assessments in General Practice. That module actually covers in detail all the requirements in terms of, Medicare items, what we can claim, what we cannot claim, how we go about it, but then also, obviously, as the title suggests, it looks at how do we use technologies like smart recalls to support our efforts in practice. So I would highly recommend that if you haven't already, check out that course, which is available now. In terms of what's the role of GP management plans in heart disease, well, GP management plans are a great vehicle for chronic disease management. So they're a great vehicle in the sense that obviously they provide funding for the practice to be able to allocate time, either the nurse's time or the GP time, to put together a plan. But they also are a great referral vehicle, as we all know, because patients will often come in requesting those referrals to Allied Health. So it does provide us with an opportunity or an avenue to give patients subsidized referrals to see the dietitian, exercise physiologist, or other health providers, diabetes educators, and things like that. One of the areas of caution, however, when it comes to heart disease and management plans is that when we're looking at eligibility for a patient to be put on a plan, Medicare says, well, look, we don't have a set list of conditions that are yes or no. We know CHD is fine to go ahead, but if you have a patient who only has high blood pressure and nothing really else is happening, or just has a bit of an issue with cholesterol, but again, there's nothing else really going on, those things are actually more considered risk factors towards developing heart disease rather than heart disease in and of itself. So we just want to be mindful that when we're going through a database and inviting patients to participate in GP management plans, that if it is a heart disease related patient, that it's not just a matter of, it's a little bit of high blood pressure and let's put you on a plan. We do actually need to have a formal diagnosis of coronary heart disease or CPD. Obviously, if you've got patients with symptoms, so people who have either chest pain and they're going through management for that, or people who have had actual events, cardiac events, that a heart attack or stroke, they're obviously fine to go ahead. But yeah, just be careful with those that are just high blood pressure, high cholesterol. For more information, check out that CPD module, because again, there's a wealth of information there. I also wanted to show you the template that the Heart Foundation put in place for a GP management plan for coronary heart disease. And this is just 2 pages. It's actually quite lengthy. So there's another 2 pages, but it's quite detailed as well. So you actually have very clear recommendations and almost prompts and guidance in terms of medication, but also it'll cover things like lifestyle factors and other issues or other areas like immunization, making sure that our patients are up to date with their immunizations, the flu, the influenza, pneumococcal, whatever it is, yeah? Especially with these patients at higher risk. Now, the last thing that I wanted to address is the practice systems, because this is pivotal and this can be key. This can be the difference between a well-run, smooth, proactive health promotion or heart disease prevention initiative in your clinic, or a complete ad hoc reactive, not disaster, but just obviously less than what it could be, or not reaching potential. So in terms of practice systems, what we're looking at is, obviously one of the key things is recruiting patients, not just recruiting them by getting them into the clinic, but also by recruiting, I mean engaging them, getting them to actually want to be part of this care and take ownership of managing their care. Some of the common issues that we find: usually poor communication with patients, and what I mean by that is we're just not using the right methods to let patients know of what initiatives we're running, be it care plans or being just screening. There's no reason why your practice couldn't just run an initiative where we're providing a free or bulk billed absolute risk screening for all our patients over 45, for example. But again, it's how we're communicating this. And as an example, you could have posters or signs in the waiting room. You could feature these activities either on your practice website or on the on-hold message. So when patients are on hold waiting to talk to the receptionist to book an appointment, they're getting informed about the different initiatives that you have. Also making sure that the language that we use to promote these initiatives is patient-friendly, because usually a lot of the times we use a lot of medical jargon, or it's copied and pasted directly from something that Medicare put out, and it's just full of words that make no sense or mean nothing to the patient. And the other issue that we find is inconsistent recall and reminder process. So making sure that you have a really robust recall and reminder system is quite important. In terms of recall and reminder systems, obviously I'd go amiss if I didn't mention the smart recalls technology that HotDoc has, which obviously the purpose of it is to automate the process of recalls and reminders based on the practice preferences. So the other thing that it includes is obviously there's a secure and privacy compliant mobile message, and this is essentially the process. It's a 3-step process where first the patient gets a privacy compliant mobile notification. No health information is released until they actually step to verify their identity. So we actually have 3 points of identity check. They just verify their surname and their date of birth, and obviously we've already got their contact number. And then finally, once they've successfully verified, they can actually see full details of their recall. But what it also means is that we've actually been able to create patient-friendly templates with wording that again highlights the benefits of attending for some of these initiatives. So why is it important? Why do you want to attend? As opposed to just saying, hey, you're due for this, and leaving it at that. Okay. I've also added a blueprint, which I cover time and time again, but the reason why I cover it time and time again is because it works and it's actually quite effective. So this is a 12-month plan. This is what I do whenever I'm in a clinic and I'm setting up a care planning clinic or health promotion clinic. These are the steps that I follow. First step is obviously we need to prepare the practice. Make sure that we are communicating with patients, having posters or signs in the waiting room, and to let them know of the initiatives that we're running, but also that the entire staff is on board, so that the receptionists, the GPs, practice manager, the nurses, like we all know what we're trying to achieve. And it's not a matter of then, the nurses know, but then the patient calls, the GP had no idea about it, the receptionist has no clue where to put them, place them, how to book them. So again, it's very important to, before rolling these things out, making sure that you have a staff meeting or memos and make sure that you're all on the same page. Then we'll be looking at the database to search for active patients, and we can filter them either by diagnosis, so we might be filtering by CHD, CPD, whatever it is, or by medication group. So the majority of clinical softwares will allow us to actually get a list of patients who are currently taking medications from specific groups or classes. Obviously, we'd be targeting people with ACE inhibitors or anticoagulants or whatever it is. Having said that, just keep in mind that it's important that we don't just assume these patients have heart disease, because again, they might just have a risk factor, but not actual full, complete heart disease. Before we call them in specifically for something like a care plan that has a fairly strict eligibility criteria, then we have a look at that patient file and go, well, actually, overall, they do meet the criteria. Or if they don't, you can still invite them for a more of a health promotion type activity, which again, you can bulk bill or you can charge. A lot of patients will still happily pay for something if they see the value in it. Again, you can invite them for absolute risk assessments and kind of lifestyle modification and support sessions, which can happen with the nurse or the GP. Okay. Now, if we keep going, step 3 would be determining Medicare eligibility. If you're going to be offering care plans and management plans, which obviously can be a great carrot or a great attractive thing to do, because it can lead to those referrals, those subsidized or partially subsidized referrals, because a lot of allied health obviously charge payments or gap payments on top. When you're checking Medicare eligibility, you can either do it online, it's through the HPOS online, or if you're ringing Medicare, you can check up to 7 patients per phone call if you ring the provider line. And the other thing that we'd be doing is, obviously, if we highlight patients who would be eligible, flag those files so that opportunistically, even if they don't respond to a letter or a recall that we've sent them, if they come in for something else, then the GP or the nurse can go, oh, hey, by the way, did you know you're also eligible for this service? This is how it works, and this is what you get from it. Okay? Then the next thing would be, when you're booking the appointments, making sure, obviously, if you're doing something like care plans or things like that, that the receptionists understand the length of time that they need to book the appointment for, that it's not just a 10 or 15-minute appointment, and whether or not, if you're going to do tandem appointments where they're seeing the nurse first and then the GP, how that's going to work. So in an ideal world, in an ideal scenario, you'd have a session for 20 or 30 minutes with the nurse, immediately followed by a standard consultation with the GP. Yeah? So you can complete all paperwork and everything in the one day in session, and away you go. But that doesn't necessarily always happen. If you are going to have to do it over multiple days, just make sure you let the patients know beforehand so that they don't get the nasty surprise of, oh yeah, fantastic, thank you for coming. Now you're going to have to come back again in 2-3 days time. The other thing is making sure that once you're getting patients through this kind of health promotion process, we add them to the recall database. And obviously, if you've got a system like Smart Recalls that automatically detects as patients become due and it starts sending out the messages, fantastic. If not, if you've got a manual process, that's fine. But if they haven't been added to that recalls database, there's no way we're going to remember to send them any notification. The next thing is when we review the progress. So once we've got our list of patients, I usually like to review progress of my 12-month plan or my 12-month list of patients at 3, 6, and 9 months. And then after 12 months have gone by, I'll start a brand new list from scratch. All right, and that comes to the conclusion. I think we've got 1 minute, gone 1 minute over. That comes to the conclusion of this session. Hopefully you found a lot of valuable information, if not valuable resources and tools that you can go back and play with and share and use with your patients. If you've got any questions, again, make sure that you write them through, or if you have any questions that come up after the fact, you can send them through to myself via email. That's md@hotdoc.com.au,